in the absence of more serious market-based, market-reformed regulations to ensure that competitive marketplace, my fear is that independent physicians are going to be squeezed out. And that is not to blame either side of the current state. It is the playing rules of the game that we have right now that is going to lead to that condition.
Welcome to Off the Chart, a business and medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Austin Littrell. I'm the Associate Editor of Medical Economics, and I'd like to thank you for joining us today. Before we get started, just a quick note, Physicians Practice will be hosting Practice Academy's new practice management track on Thursday, March 19th. If you're listening to this on the week it released, that's this Thursday. The virtual learning experience is designed for physicians and practice administrators looking for practical, real-world strategies to strengthen operations, improve performance, and build more resilient practices. Speakers include Anders Gilberg of MGMA, Bronson Cox of Encoda, Justin Lamb of Cool Blue VA, and Mark Herzog of Veradigm. You can register today by clicking the link in the show notes or by going to registration.physicianspractice.com. That said, in today's episode, Medical Economics Senior Editor Richard Payerchin sat down with Charles Miller, the Director of Health and Economic Mobility Policy for Texas 2036. That organization was behind an in-depth study of healthcare access and affordability in the nation's second most populous state. They're talking about why Texas has long carried the highest uninsured rate in the country, what research by Texas 2036 revealed about who the uninsured actually are, and why so many eligible Texans still haven't signed up for coverage that they could get for free. Charles Miller, thank you for joining us, and now let's get into the episode.
I'm Richard Payerchin, reporting for Medical Economics. With me today is Charles Miller, Director of Health and Economic Mobility Policy for Texas 2036. It's an organization that has made an in-depth study about healthcare access and affordability in the nation's second most populous state. Thank you for joining us today.
Thank you. Glad to be here and happy to chat with you and your audience.
We're going to get into some nuts and bolts on healthcare policy, but before we do, can you introduce yourself and the healthcare work of the Texas 2036 organization?
Sure. So my name is Charles Miller. I am the Director of Health and Economic Mobility for Texas 2036. Our work around healthcare has really focused on two big factors. That is increasing the number of people in Texas who have health coverage, health insurance, and then also working to make the underlying prices of healthcare more affordable so that people are able to access the care they need when they need it at a price they can afford.
The year 2036 is going to mark a special year for Texas. The organization is not exclusively a healthcare business or nonprofit, but in many ways is getting ready for Texas's bicentennial, as I understand it.
That's right. So we are working to make sure that, and no offense to some of your listeners from other states, Texas remains the best place to live and work by our bicentennial, which is measured from the birthplace of Texas as a nation back in 1836.
There's any number of social and economic issues that different organizations will take on. Why did Texas 2036 make healthcare policy a priority in recent years?
Texas has struggled, many states have struggled with this, but Texas has uniquely struggled with health insurance in particular. For years and years, Texas has had the unfortunate designation of having the highest uninsured rate, as well as the highest number of individuals without insurance. And that has been a sore spot for a lot of folks in Texas. So we saw this as one area that we could work to take on. As we got into that work, we also realized that it's not just simply limited to the issue of coverage and getting people covered, but that there is a broader ecosphere of making sure that the overall systemic nature of our healthcare system is affordable. And that goes beyond simply looking purely at insurance, but making sure that the entire system has affordable prices that remain accessible both to individuals, but also to the state as a whole.
Texas 2036 conducted a deep dive in the state population to ask, who are the uninsured? What were those findings, and how do you answer that question? Who are the uninsured in Texas?
So we were really prompted by this by what seemed to be some incongruities with the data that we were looking at. One of the big questions and the biggest source of data that we had for this question is, well, why are you uninsured if you are uninsured? And the existing source of data came from the American Community Survey, and the overwhelmingly top answer was it's unaffordable or it's too expensive. And we started looking at this and started doing some demographic breakdowns and looking at crosstabs. And our back of the envelope calculations were that a huge chunk of the folks who were saying that affordability was the reason why they were uninsured were actually eligible for free or very inexpensive plans. And so we wanted to go deeper than this survey and really start to find out what are these answers getting at? What can this tell us? And so we did something radical. We asked the people themselves, who are you? Tell us about your life experiences. Why are you uninsured? What are your perceptions or awareness of various programs? And the results we got were pretty interesting. I think one of the findings we found is that a lot of people who were uninsured because they thought they could only get insurance through their employer. And so if they were unemployed or if their employer was not offering insurance, they simply didn't know that there were other options available. The other big barrier that we found is that people had a very different perception of what insurance would cost to them than the reality. And so this is getting at that disconnect that we saw earlier in that survey response to the American Community Survey. When we talked to people, we would get enough demographic information that we felt pretty good about being able to estimate what their out-of-pocket premium or enrollment cost would be. And then we asked them, what they thought that it would cost. And the disconnect was extreme. A lot of folks who were eligible for free or say under $25 a month plans had a perception that they were going to have to pay $300, $500 a month. Some of those perceptions were based in reality. They had done past work and conditions had changed. Some of them were based on almost vibe casting. They just had a sense of this. And some of it was a different perception of their place in society. And this last group, what we would hear is, insurance isn't for someone like me. And that's a direct quote. We heard people say things like, insurance is like a luxury handbag. It's just something that I'm never going to have. But going back to that first group of people, when the Affordable Care Act first rolled out, and it was available back in 2014, 2015, and people went on, prices that they saw were much higher than they are now. Affordability has just increased for a number of reasons due to state and federal actions, and the prices that are available now, and especially at the time that our survey and focus groups were being conducted, had changed dramatically. And so for those folks, our message was, go take another look. This group, I would say, was probably the smallest group that had actually gone on previously and had a very data-informed opinion. The larger group, we think, seem to be getting their perceptions of affordability largely from media coverage talking about premium increases and gross premium increases, as well as maybe just political perceptions of the program based on their political news. And to those folks, our message was, go take a look at this and go in with an open mind and just check it out. When people found out that they were eligible for plans that were, again, under 25, under 50, and in many cases free plans, that really changed their views of what was available for them. Now, there were other groups of people and other reasons that compounded on these, but those were the big factors, the biggest factors we found as to why the existing population that was eligible for these plans had not signed up. And the numbers are wild. Right? So we had 5 million uninsured folks in Texas, and our calculations at the time was roughly 40% of them were eligible for a free plan. Now that was in the world where we had the enhanced subsidies still in place that have since expired. Those numbers are a little bit lower now than they were, but we would still estimate that of the uninsured, a little over 1 million of those folks are still eligible for a free plan and had not signed up at that time.
You know what, we've been talking quite a bit about a kind of a consumer and patient perspective. And that's important because I always like to think about our audience has both a career and professional interest in promoting good health and frankly, a financial interest. When people go to the doctor, our physician audience gets paid when they have patients. I wanted to sort of bring it back to our physician audience a little bit and ask about, when you talked earlier about the notion of the uninsured level in Texas, and then actually Texas 2036 really getting into the diving into the data into patients. Were doctors involved in any of the creation of these policies, and maybe what has the response been?
We have a very active medical lobby here in Texas, and so when we're looking at state level policies, there are all sorts of physician groups that are involved in the crafting of those policies. During any given legislative session, I work and interact regularly with those individuals. One of the policies that has actually had a unique impact in Texas and has made some of those bronze and gold plans more affordable was a bill that was passed back in 2021. And this was a bipartisan bill that actually enforced the ACA's single risk pool requirement more stringently than a lot of other states did. And that might sound odd or interesting that Texas would have such a strong interest in enforcing the ACA's requirements. But the reason we did is that it had this really beneficial impact in that it increased the amount of tax credits or subsidies that were available for folks who were purchasing those bronze or gold plans. So to bring it back to your audience, in terms of their interest, the way that the plans operate, just as a general matter, is they're rated by these metal levels, right? So there's bronze, silver, and gold. And the different plan metal levels are supposed to correspond roughly to plan generosity. So a bronze plan is the least generous plan. It'll have the highest deductibles, the highest copays, and so forth. The silver plan is kind of this mid-range level, and then the gold plan is the most generous. Except that there's also this other weird factor that if you earn less than 250% of the federal poverty level, silver plans and silver plans only have what they call these extra cost sharing reductions. And that brings down the deductibles and copays to a very, very low amount. So when the Affordable Care Act was first coming out, a lot of the discussion among provider groups was that these plans were going to be less appealing for doctors because they had higher deductibles and higher copays than maybe a more traditional employer-sponsored insurance plan. There's a wide variation among these plans, and if we are talking about a relatively low income enrollee who has a silver plan, they actually have a very, very generous plan level, and the expected out-of-pocket cost contribution from those patients is going to be very low. So there's less perhaps having to keep track of that patient cost share amount from a financial perspective for your folks. But there are wide variations. Again, a bronze plan could have deductibles that are, exceeding $10,000 in some cases, and gold plans tend to be more generous. But there's wide variation within the plans, and so there is no one single answer from a physician standpoint of looking at the patient and, oh, well, you've got a gold plan, that means that your cost share is going to be lowest. It's a little bit more complicated than that, unfortunately. So there is no one single filter to look at for which one is going to be the most business-friendly plan for me.
You know what I had, and I'm glad you touched on that because I did have that in kind of the list of questions that I wanted to ask about. When you talk about that as a policy in Texas, are you familiar with any other states that have really pushed or promoted that level of, I don't want to say enforcement, but just making sure that those provisions within the Affordable Care Act really are carried out to the benefit of both patients and physicians?
So yeah, we call this policy premium alignment, and it works by just making sure that the premiums that are charged for any given metal level of plan correspond to the generosity as stated on paper. And so that's making sure that the relative premium price corresponds to the relative generosity of those plans. Other states have explored this. We have recently seen Illinois is probably the biggest state that has looked at this, but especially as the subsidies, the enhanced subsidies are expiring, states have gotten very, very interested in this policy because it does make those bronze and gold plans more affordable by bringing in more federal subsidies for those plans. I have talked to a number of folks that are working on these policies in other states. I don't know that I'm at liberty to name any of the ones that don't have a bill publicly filed right now. But Illinois is definitely the biggest one. New Mexico has worked on this in the past and actually was a first mover before Texas was. And then the other state that's interesting, it's a very tiny population, but it was where this dynamic was first discovered, is Wyoming. They haven't actually taken any specific state action to do this, but their marketplace just had the dynamics and such that we were able to see those mechanics and put them into operation. I would expect that we'd see this sort of policy spread to other states as it's gaining a lot more attention nationally, though.
Question for you, and it may sound a little tangential for our audience directly. However, it is something that has gotten a lot of attention, I would say, in the last couple of years. Especially on the national campaign trail, frankly. Immigration and border security have become flashpoint issues in our country, especially in the southern border states. What happens to undocumented people when they get sick? Is there any health care available in Texas for people not legally present in the United States?
So I want to separate out the issue of healthcare from, say, government subsidized health insurance or coverage programs, because those are two different aspects of things. There is no law, prohibition, or barrier to anyone going and accessing healthcare in Texas or nationally. A lot of the restrictions that do exist center around how it will be paid for and what programs or eligibility there is. In Texas, there is no eligibility for traditional Medicaid or certainly for ACA subsidies for those who are here without legal status. There are programs that will provide some reimbursement and coverage in emergency situations for those individuals, and that's true in every state. Other states have taken the approach of directly funding or subsidizing program or eligibility for folks without legal status, but that has not been the case here in Texas.
And to continue along, maybe with some of the other policies, recently, Texas 2036 had published the 2025 health accomplishments, and there were three key themes identified for Texans that I would like to maybe talk a little bit more about. There have been efforts to expand price transparency and access to actionable information. Can you talk about that legislation that has been approved and why that issue is so important?
So there's been a long train of price transparency efforts going back to, I think, 2017, when there were first some federal regulations that were proposed. In Texas, going back to 2021, we codified those federal regulations and put them into state law so that they would be enforced. And they applied to two different groups. The first was hospitals, that hospitals had to release annual price transparency files showing their real negotiated rates for various services and put them on these machine-readable files. They also had to put forward a list of 300 quote-unquote shoppable services on their website as well. The other side that this applied to was to insurers, and this is not just actual insurers, which would mean fully funded insurance plans, but also anyone who is offering a health benefit plan. So even your large employers who have, say, ERISA-protected self-funded plans, they also would have to put out these files. And those files had to be put out monthly. Again, they are machine-readable files, and they include specific negotiated rates that include the specific provider and the specific procedure at place. They also had to provide a consumer self-use tool available either on the website, on an app, and also to call in, where you could look up a particular healthcare procedure and then get a list that would be sortable by geography with a provider-specific name and then what your cost sharing would be based under your plan. A lot of the discussion around how to do price transparency conflates a couple of different things. And what we look at when we're talking about price transparency is twofold. One, how can we make prices and the extent of price variation that exists more accessible to what we would call institutional purchasers? And institutional purchasers could be insurers, but frequently it's employers, because more than half of the country and half of the state of Texas gets their health benefit plan through their employer. And employers were reporting that they just really had no insight into what the prices were for these services that were their employees were receiving, and therefore couldn't craft intelligent benefit designs to encourage their employees to go get high-value care. The other side of this, and this is the one that I think gets a lot more attention, is the consumer side of it. How can we make prices available to the consumer and create an informed, engaged, shopping-savvy consumer? The machine-readable files that I talked about previously, those efforts really are not consumer-friendly. I am able to play around a little bit with those hospital files. They are accessible to somebody like me who has a little bit of training with data. The insurer files are way too complex for me. I have to go hire experts and consultants to look at this. There is no way that any consumer could look at these machine-readable files. Where the consumer efforts were tried to be geared at is that insurers, these self-service tools, would give the consumer their out-of-pocket cost, because that's usually what's going to be the biggest motivator of the consumer is, I don't really care what that price is that was negotiated between the insurer and the healthcare provider. What am I going to have to pay out of my pocket? And that's the thing that is motivating more of that behavior. So with that as kind of a backdrop, What we've done more recently in Texas is there was an effort to expand the price transparency requirements on the provider side, not just to hospitals, but to other non-hospital facilities as well. And so that would be, say, ambulatory surgical centers or birthing centers, other facilities that are not hospitals would have to have those price files put out there. There's also been more consumer-focused price transparency efforts. One of them was in requiring itemized bills to be issued to every consumer before there is an attempt to collect on that debt by hospitals that went forward. One of the efforts that went through this session was to ensure that providers would give patients a specific enforceable cost estimate. And so if you are shopping around, maybe you don't necessarily know if you're going to have, say, a more complex surgery that's going to be done in a hospital, you may not have all the information to go punch into your insurer self-service tool and get, here's what is this going to cost me. So the idea was that if you go to the hospital or the surgery center and you ask, hey, what's this going to cost me? Here's my insurance card. I want to know what the final out-of-pocket cost for me is going to be. That they would give you an estimate on that, and that estimate couldn't vary all that much. There's a bound of allowable variation, and then there are exceptions in case there were complications that arose or there was a change in diagnosis that came up during the procedure. So those are some of the aspects in terms of price transparency that have been worked on more recently here in Texas. But there's still more work to be done. But there has been, I think, of all of the efforts of what we call a healthy market, one that is informed, competitive, and engaged, price transparency has been probably the area where there has been the most work that's been done.
Hey there, Keith Reynolds here, and welcome to the P2 Management Minute. In just 60 seconds, we deliver proven, real-world tactics you can plug into your practice today, whether that means speeding up check-in, lifting staff morale, or nudging patient satisfaction north. No theory, no fluff, just the kind of guidance that fits between appointments and moves the needle before lunch. But the best ideas don't all come from our newsroom. They come from you. Got a clever workflow hack, an employee engagement win, or a lesson learned the hard way? I want to feature it. Shoot me an email at kreynolds@mjhlifesciences.com with your topic, quick outline, or even a smartphone clip. We'll handle the rest and get your insights in front of your peers nationwide. Let's make every minute count together. Thanks for watching, and I'll see you in the next P2 Management Minute.
And to continue along with some of those 2025 themes, more than 60% of Texans live in metro areas with highly or very highly concentrated hospital markets. There also has been legislation increasing options for obtaining care and improving rural access. Can you discuss some of those policies?
A lot of the efforts around increasing rural access is focused on making sure that rural hospitals remain a viable option. I don't know that necessarily that is going to be a long-term solution, but in the short term, until there is a re-envisioning of care delivery mechanisms in ways that I don't know that we have the answer to, keeping that life support system afloat is important. So the legislature has spent effort on funding grant programs for those, and then at the federal level, we recently saw the $50 billion in the Rural Healthcare Transformation Fund. Still trying to figure out the details of exactly what that is going to fund. Each state has their own plan there, and to be perfectly honest, I haven't read through the entire state of Texas approved application on that to find out what is or what is not yet going to be an allowable expense. The other aspect of that question, concentration and consolidation of care has become a real problem that inhibits competition and has been inhibiting choice. And so we've seen increasing horizontal consolidation, and that's the type we talk about where a hospital system goes out and acquires additional hospitals. We could see it in any level of the medical delivery system. If an insurance company goes out and buys out a competing insurance company, that's what we call that horizontal consolidation. We've also seen increasing vertical integration and vertical consolidation. And so that would be where, say, either a hospital system or an insurer goes out and acquires or controls a primary care practice. And in that case, sometimes what we see is that the vertically integrated system will use that vertical integration to inhibit competition and choice in a service delivery horizontal that could be competitive. So we talk about how the hospital market is already highly concentrated. In some cases, there is functionally only one hospital choice in a given delivery area. If you had that, hypothetically, but you also had a pretty wide variety of primary care providers in that area, we would still have the potential for competition in the primary care provision delivery. If that hospital group were to go and acquire, control, purchase in some way some of those primary care providers, it could now functionally make that primary care practice group or the primary care horizontal less competitive by tying the availability of their monopoly service, the hospital, where they're the only game in town, to also the inclusion of those primary care practice providers at a preferred tier in a network plan. And so you can imagine the complex contract negotiations that go on between benefit plans and health systems and the ways that those can be abused. And this isn't limited. This isn't to call out hospitals. We see insurers are doing the same thing. A certain large insurance company happens to also be the largest employer of physicians in this country. And there have been allegations that they may be using their benefit plans to steer their enrollees to their wholly owned or controlled physician groups, not because it's necessarily the best thing for the patient, but because that's a way that they can increase their profit lines. So a lot of the work that we've been doing around consolidation is looking at, first, where can we preserve competition where it still exists? And then secondly, where consolidation has already happened, what tools do we have available to us to mitigate some of the harmful effects of that consolidation? One of the big efforts that we saw on this was a bill that passed a couple of years ago, House Bill 711, and it was to prohibit certain anti-competitive contracting practices. And this was, again, we try to look at this as what creates a fairer functioning marketplace. And so we went after contracting practices that existed that were utilized by both sides, or all sides, I should say, in the contracting disputes. Some of the ones that we looked at were anti-steering or anti-tiering provisions. And these are provisions where a large health service provider would have a dominant market position. They would use these, as we talked about earlier, to prohibit an employer from steering their employees to go seek care at a place outside of the providers within their system. So if they are going to have a tiered network plan, then all of the providers within that health system would have to be at the most preferred tier, regardless of their price, regardless of their quality. Similarly, we would see that some insurers, if they had market dominance, would use what's called a most favored nation clause, where any provider where the providers would have to give that insurer the lowest price that they were charging anyone. And so this inhibits competition on the insurer sphere so that a new insurer could not come into the market and gain, say, market share by offering higher reimbursements, or a doctor couldn't get in there and take a lower reimbursement to drive up their market share. So this is a way that they inhibit the competitive forces of the market by having some of these anti-competitive clauses. The other one that we see, and it runs rampant, was gag clauses. And these are simply clauses that prohibit folks from informing more people about what's going on. And sometimes it actually acts to inhibit physicians from knowing what it is that they would, what they are going to be reimbursed for a service. Sometimes they were being used to prohibit physicians from telling their patients about the availability of certain services, or the fact that maybe paying in cash might be cheaper than the insurance price. We saw this frequently in the pharmacy space, where pharmacists would be prohibited from telling patients that would come up that if they paid cash, it would actually be lower than their copay for certain drugs. So there has been efforts at the federal and the state level to go after those gag clauses. There are other anti-competitive clauses out there that we haven't addressed yet, so that's an area to watch. I do know that there's interest on both sides of the aisle here in Texas at looking at how we can make our markets continue to be competitive and healthy so that we can get that high-quality care at the lowest price for Texans.
Traditionally, the audience for medical economics has been independently operating physicians, and especially those in small and medium-sized practices, and especially in primary care. And all those policies that you had talked about here just a moment ago are like exactly on point for what we have been covering now, at least since I've been at the company, and even long before I got there. So it's one of the things I find fascinating is that just given different market conditions and geographic diversity of our nation is that sometimes out of Washington, it sounds like there's a policy that may sound like a good idea, sometimes has unintended effects, or perhaps is not as effective in certain areas as in others. And to hear about some of those solutions at the state level, like I said, I think it's just a great conversation. We could probably talk about that the rest of the day.
I mean, what we think, our perception here is that especially independent physicians have been squeezed by both of the large behemoths at the system. And that is whether that is a large integrated healthcare system that is usually headed up by hospitals, but it's also being squeezed by the large insurance companies. And independent physicians, what we have seen and what we tend to see is they want to be able to practice and have that relationship with their patients so that they are free to practice medicine and take care of the patients as they see fit without meddling either by a large corporate health system or by a large insurer dictating the type of care that they receive. And we think that that's important because it is that physician-patient relationship that makes sure that the patient is the one that is being treated and is not then the care serving interests other than the patient's.
Our main audience is primary care physicians. What would you like to say to them, or what would you like them to know?
What I would say is it is getting harder than ever, and this is nothing they don't know already, to maintain an independent practice, and that if independent practice is something that the primary care physicians wish to see the viability of that continue to increase, there's going to have to be something done about market consolidation to maintain the viability of these practices. In the absence of more serious market-based, market-reformed regulations to ensure that competitive marketplace, my fear is that independent physicians are going to be squeezed out. And that is not to blame either side of the current state. It is the playing rules of the game that we have right now that is going to lead to that condition. So if you are an independent physician, get active, make your voice heard, and make sure that the groups that say they are representing you are actually representing the interests that you have of maintaining that ability to practice independently.
I'm Richard Payerchin, reporting for Medical Economics. My guest today has been Charles Miller, Director of Health and Economic Mobility Policy for Texas 2036. It's been a great conversation. Thank you so much for taking the time.
Happy to do it. Wonderful questions, and would love to come back anytime.
Once again, that was Charles Miller, Director of Health and Economic Mobility Policy for Texas 2036. He was speaking with Medical Economics Senior Editor Richard Payerchin. On behalf of the whole Medical Economics and Physicians Practice teams, I'd like to thank you for listening to the show and ask that you please subscribe so you don't miss the next episode. And don't forget, Physicians Practice will be hosting Practice Academy's new practice management track this Thursday, March 19th, featuring practical, actionable education for physicians and practice administrators. You can register today by clicking the link in the show notes or by going to registration.physicianspractice.com. As always, be sure to check back on Monday and Thursday mornings for the latest conversations with experts sharing strategies, stories, and solutions for your practice. You can find us by searching Off the Chart wherever you get your podcasts. Also, if you'd like the best stories that Medical Economics and Physicians Practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at medicaleconomics.com and physicianspractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Littrell. Medical Economics and Physicians Practice are both members of the MJH Life Sciences family. Thank you.